This is going to be Introduction to Capnography. And topics we're going to discuss in this slide set is going to be general orientation to capnography, what we get out of intubation patients and the applications. Examples of this would be full arrest, non-intubated applications, cardiac dysrhythmias, asthma patients, what we would see in possible pulmonary emboli, quick waveform review, and then a quick summary. So first of all, we're going to talk about orientation to capnography. So we're in this section, we're going to look at capnography terms, the respiratory cycle, pulse oximetry, normal values of capnography, and the capnographic waveform. General terminology, capnometer, a number that identifies how much carbon dioxide the device is reading. So the number that we actually see on the readout is the capnometry. The capnograph is a diagnostic monitoring of the pulmonary function plotted against time. So the waveform is the actual capnograph. This is going to be a quick overview of the respiratory cycle. So respiration starts by taking air in. So whenever we breathe air in, we load oxygen on the red blood cells. So the returning supply that's coming into the pulmonary trunk to be oxygenated has a decreased amount of oxygen attached to it. It actually has CO2 attached to it. So we expel the CO2 and we breathe in the oxygen. So then the oxygen travels on the red blood cell through these pipes to the business end of things, or the tissues. Now the tissues, to their perspective, they have used up all the previous oxygen and have now created CO2. And we'll explain that here in just a second. The Krebs cycle. CO2 is one of the is essentially a cellular tailpipe. So to this muscle's perspective, it gets fed with oxygenated tissues, and then it expels CO2, which then load to the red blood cells that are coming by because they are offloading their oxygen and picking up the CO2. The CO2 then returns right here on the venous side or deoxygenated side into the heart. And then the heart pumps it into the lungs, and the lungs reoxygenate it. Now, that's the overall general process. At the cellular level, this down here occurs. We have two forms of metabolism. We have aerobic and anaerobic. Aerobic means with oxygen, and anaerobic means without oxygen. Aerobic metabolism is the best way to generate energy. We have low amounts of energy if we do not have oxygen to feed essentially the Krebs cycle. The cellular tailpipe on the Krebs cycle is CO2. So our cellular environment produces CO2 and water as an end process of the actual Krebs cycle. The CO2 then is expelled on the red blood cells back through the respiratory system, and then your exhalation is what we see in that. Now the end-tidal CO2's part in this is it takes a look at the CO2 that is expelled and will give us an overall look at this entire process. Are you moving red blood cells through the system appropriately? Pulse oximetry, the standard of care and out of hospital setting. Should be applied to patients to help establish a baseline vital signs. SpO2 between 95 and 100 is normal. SpO2 between 91 and 94% is mildly hypoxic. We should probably assist them a little bit. SpO2 between 86 and 90 is moderately hypoxic. And SpO2 levels below 86 is severe hypoxia. We should be careful of low perfusion states. CO poisoning will give us aberrant signs on this as well. CO poisoning could give us an SpO2 of 100, but I will assure you at the cellular level, they don't have 100%. Pitfalls of this: cold fingers, poor perfusion. So just be aware of that as we're looking at the pulse oximetry. This would be one viewpoint, and the only thing that it sees is how much the red blood cell is loaded with oxygen. Now, if the person is anemic, this could be a pitfall as well. They could have two red blood cells, but they're loaded at 100%. Capnography normal values. Normal values for capnography is going to be 35 to 45 millimeters of mercury. Hypoventilation, we're going to see more capnometry or capnometry level greater than 45%. So as our body starts retaining CO2, the CO2 levels start to rise, and we'll see this in the gas sampling. Hyperventilation blows off too much CO2 and it will be under 35 millimeters of mercury. So low CO2s. 35 to 45 is the normal CO2 level. The normal capnographic or CO2 waveform. Now, we have various spots in this. This first one here, or phase 1, is respiratory baseline. It represents the beginning of exhalation of CO2, free gas that is contained in dead space from the conduction of the airways, and that would be the trachea and the bronchi. This value normally is 0, so this is where our respiratory baseline should be, and we should see no CO2. Phase 2 is the expiratory upstroke. A sharp rise represents exhalation of the mixture of dead space gases and alveolar gases. So as we start exhaling, we start to see CO2 come out of the sample, and that's this expiratory upstroke, or phase 2. Phase 3 should be slanted upward, and this appears the peak measurement, or the capnometry. So if the number on the machine read 38, this is where it would be reading that from. This alveolar plateau here that we take a look at in phase 3, characterized by exhalation of mostly alveolar gases. The highest point is the end-tidal CO2 value, and that is recorded and displayed by the monitor. Peak concentration of CO2 occur at the end of expiration. The millisecond before inhalation is the maximum amount of CO2, or the end-tidal CO2. And that would be this number up here that we've already talked about. This is the alveolar plateau. Slowly rises until it is at a peak measurement. Segment 0. A sharp fall reflects the inhalation of gases that are CO2 free or have a higher concentration of oxygen in them. So as we start inhaling, what we see is we see all of the CO2 sampling that we're looking at kind of go away. So this is our inspiratory downstroke right here. So again, baseline, this should be 0. Inspiratory upstroke, our alveolar plateau. This is the capnometry, or the end-tidal CO2, generally measured in a number of millimeters of mercury. And this is our inspiratory downstroke. Now, we have to understand this to take a look at what might be aberrant or what might be diagnostic if we see it. Types of detectors. There are 2 types out there. There are mainstream and sidestream. Mainstream, sensor on the hub, picks up a reading directly, and they're kind of notorious for clogging. A side stream, sensor on the machine, aspirates air through a line on the machine, and there's generally no clogging issues without this. However, vomit can come out of the tube and can clog even a side stream. So just be aware of that. You may have to actually change even these devices here. Now, they have multiple devices with this. This is the nasal cannula version that kind of has a cup for the patient to breathe out in, or they have an end-tidal CO2 version that goes on an ET tube and a standard BVM connection. Alright, the intubated patient. A couple things we get really quick off of the intubated patient and monitoring an intubated patient with end-tidal CO2 is, number 1, verification of tube placement. If we get capnographic waveform, that tube is in the right location. And it also gives us a continuous monitoring of tube placement. So if all of a sudden we had great capnographic waveform and good numbers, and then all of a sudden it just drops off the face of the earth, there's a good chance that either we have mucus plugging, 1, or 2, we might actually have extubated the patient. So very simply, can't make this any simpler than this, the esophagus should not have CO2 in it. So if the tube is in the right location, or the glottic opening or the trachea, then we should see expired gases if we have any perfusion at all in the chest. There's no CO2 in the esophagus. Continuous monitoring of tube placement. It gives us a minute-to-minute, second-to-second look at ventilation, and this occurs in real time. In cardiac arrest, it tells us CPR effectiveness. So if we're not doing chest compressions well, we won't get cellular perfusion or see the cellular perfusion or the cellular sampling of the gases coming back. We won't have enough perfusion to make that happen. So we'll have low end-tidal CO2 levels. So maybe that would key us into increasing chest compressions even more. It also gives us the earliest sign of a return of spontaneous circulation, and it also helps us track cardiac output. So first of all here, CPR effectiveness clearly shows cardiac output even by artificial means. The end-tidal CO2 greater than 20 with active CPR has a greater chance of return of spontaneous circulation. Increasing numbers in end-tidal CO2 may suggest that your patient has actually had a return of spontaneous circulation or an ROSC. The earliest sign of ROSC. Let's say that we're in a systole PEA or a pulseless rhythm like VTAC or VFib, and we're doing chest compressions and we have these low CO2 levels, and then all of a sudden we notice, bam, CO2 levels rise, they're higher, and they're consistent. So on our next 2-minute cycle, whenever we do a pulse check, there's a good chance that we're going to have a pulse at this point. So watch your capnography best you can. So if you see an increase in end-tidal CO2, very simply, you could have just had an ROSC. Finish up your 2-minute cycle and then check for a pulse. Tracking of cardiac output. Whenever we can look at the overall when end-tidal CO2, and this would be trending version of it, CPR was started here. We can see when rescuers start tiring, CO2 levels go down. We don't have as good a cellular perfusion occurring. Rescuer replace, bam, we get a high amount of CO2. It stays consistent, and then bam, it goes off the chart. There's a good chance that in this area here, this person has had a return of spontaneous circulation. That's because now the pump is assisting the chest compressions in bringing back blood sample from the cellular compartment and bringing back CO2 with it. The non-intubated patient. Whenever we look at non-intubated patients and end-tidal CO2, we can identify things, whether the patient has perfusion in cardiac dysrhythmias or due to the cardiac dysrhythmia, am I being effective in this? Is my patient going to crash? Bronchospasm, asthma, COPD patients, and we'll talk about that and show you some different waveforms. And hypoventilative states, or low ventilatory states. First of all, cardiac output. In bradycardias, tachycardias, cardiogenic shock, and hemorrhagic shock, the end-tidal CO2 can give us kind of a glimpse. In bradycardia, the ability to see perfusion when transcutaneous pacing is captured. That would be a good thing to know. Did we get perfusion, or did we get an increased amount of end-tidal CO2? In tachycardias, consider an SVT or VTAC with a normal end-tidal CO2. This would suggest that the patient is tolerating the tachycardia okay. But the normotensive patient, that end-tidal CO2 is decreasing, states poor perfusion. So we could actually see them going into an unstable tachycardia kind of coming. In cardiogenic shock, trending in end-tidal CO2 with lower CO2 levels may indicate a perfusion problem and be one of the earliest signs of us understanding that the person is going into a pump-related shock. Hemorrhagic shock, assessing effectiveness of fluid resuscitation. Simple principle, when enough fluid is on board, perfusion and CO2 will return and increase through the sampling. So tachycardias, are they tolerating it well, or are they not? In cardiogenic shock, are they going into pump failure or not? And in hemorrhagic shock, are my fluid boluses effective or not? Bronchospasm. We're going to talk about the phases of asthma and the bronchospasm waveform in this. Phases of asthma. So what we essentially get is whatever the trigger, the body kind of releases its cellular media and cellular materials in this. This causes inflammation and an increased mucus production. It decreases the lumen of the airways, and makes this difficult to breathe. Now, it essentially turns the lungs into what I like to refer as a roach motel. Air checks in, but it doesn't check out. That's why we get high I to E's, or inspiratory to expiratory times, on asthmatics. A bronchospasm waveform is a representation of that. Our normal phases, phase 1, phase 2, phase 3, this is supposed to be our alveolar plateau. But what we see here is we see a slow fin kind of coming up. Now, what that says is that I'm having a hard time of getting ventilation out, and it's slowly increasing. Uneven emptying of the alveolar gases alters the emptying on exhalation. This produces changes in the ascending phase, or phase 2, with a loss of the sharp upslope, and it alters the alveolar plateau, producing a shark fin. Pulmonary embolism. This will flatten out or create a horizontal aspect to phase 3. Now, instead of a nice upward slope to our capnographic waveform, this will be nice and flat. Also, it may have lower amounts of perfusion, so we may only see just a little bit of gas sampling depending on how big the PE is. In COPD, understanding of this is no matter if it's increased mucoid production or it is trapping of air from emphysema, we still can have bronchospasm events. To the perspective of the entitled CO2, the waveform will still look like a shark fin. Summary of asthma and bronchospasm and COPD. Diagnose the presence of bronchospasm. It helps with that. It gives us a nice shark fin appearance instead of a nice flat elevated plateau. Assesses the severity of the asthma and assesses the response to treatment. Now, what we should see in asthmatic treatment is at first we may have very small, tiny shark fins, low amounts of CO2, and that's because they're under bronchospasm. They're still trapping air. We cannot see the full gas sample, but once we start opening them up, we will see an increased rise in gas sample, and that is until we correct the respiratory acidosis that they're currently in. Hypoventilation states, things like sedation, analgesia, conscious sedation, increasing end-tidal CO2. We should watch for the need to intubate the patient or oxygenate the patient. In analgesia, same way. And this would be both in sedation and analgesia, that if we get increasing CO2s, we may need to increase their stimulation, either assist their ventilations or put them on oxygen. ETOH, or alcohol intoxication, low ventilatory states would increase the amount of end-tidal CO2. In these, if they are hypoventilative, we will increase the amount of CO2. Drug ingestion with respiratory depression also increase the amounts of end-tidal CO2. Postictal states. Is the ventilation improving the postictal state or not? Increasing amounts of end-tidal CO2. Head trauma. Hypercapnia increases intracranial pressure. Target for head trauma or intracranial pressure would be 25 to 30, and this depends on the actual book that you get into and you actually read. But the one that I found in the Capnography book was head trauma, target ICP, about 25 to 30. Metabolic acidosis. The body goes into a compensatory mechanism at the point that it goes into an acidic state. In DKA, we can see Kussmaul respirations, rapid, deep, which would cause us to have low end-tidal CO2. We've blown off all the CO2 we can to adjust the acid-base arrangement. In dehydration, low CO2 secondary to poor perfusion and near decompensated shock. After successful fluid resuscitations, the CO2 will improve. So we essentially first see low CO2 levels, and then they start increasing until we normalize things, and then they'll go back to the normal level. In CO poisoning, if we're over 5% of CO poisoning, so a person has got dosed from a good CO open flame source. If it's over 5%, it could interfere with the amount that we see. So what this would cause us to see is low end-tidal CO2 initially, and the reason that is because the hemoglobin molecule is locked up with the CO. It can't exchange the gas as well at the cellular level. So differential diagnosis for a person that might possibly have CO poisoning should be done with a machine that can facilitate if you have carbon monoxide present. This differentiation and the values should be taken into consideration for oxygenating your patient. The example of this, if the CO is 24% and the pulse ox says 100% and your end-tidal CO2 is low, there's a good chance that they're in a hypoventilatory state at the cellular level. Load them with some more oxygen, see if we can increase that end-tidal CO2 number. At the point that they go into or start normalizing at the cellular level, and we may not be able to do this with the CO poisoning, then very simply we will start to normalize our patient. So end-tidal CO2 poisoning, we may see or CO poisoning, we may see low end-tidal CO2 presentations, and then hopefully as we start correcting them, they will also rise, or they may just stay exactly the same. Differential diagnosis should always be placed with how much CO2 does my machine see present. If it sees 24%, and the pulse ox says 100%, that's just a simple math calculation there. To the cellular perspective, they're probably in a moderately hypoxic state, if not a severely hypoxic state. Increased intracranial pressure. Patients with suspected ICP, head trauma, brain tumors, brain abscesses, brain infections, or spontaneous bleeds. Low CO2 levels causes vasoconstriction of the vessels in the brain. High CO2 causes vasodilation of the vessels in the brain. ICP patients need to have controlled amounts of CO2. Please keep the gas level steady. So if they're looking like that they're posturing up and you have a rapid increase in intracranial pressure, very simply, you could hyperventilate them a little bit and see if it subsided that increased ICP. Don't get extreme with this. Don't take them to extreme ends. So monitor. You want to just adjust it very, very little. So towards the lower end, maybe at 35, maybe at 32, 34. Start off with that, see how your patient does and interacts clinically. End-tidal CO2 diagnostic chart. High end-tidal CO2s simply refers to ventilatory problems. And low end-tidal CO2s, we can have hyperventilation because I've blown off too much CO2, a perfusion problem, or a metabolic problem. In pediatrics, the most prominent cause of pediatric cardiac arrest is because they are hypoxic. Watch for increasing levels of CO2. They have a less of a functional reserve than adults do. So they will not take a lot of high CO2 levels or high respiratory acidosis interactions before they start crashing. Always pre-oxygenate the patient before doing any intervention. They don't have a big reserve. All right, we're going to go over some waveforms here really quick. So sustained low end-tidal CO2 with good alveolar plateau. Now this could mean simply that we have hyperventilated the patient, or the patient themselves could have hyperventilated themselves, or maybe it's because of possible hypothermia. They're cold, decreased metabolism. But in either case, this would give us a low end-tidal CO2 level. And this is 40 right here. That would be a nice normal number, 35 to 45. Loss of end-tidal CO2. Multiple things. The endotracheal tube is in the esophagus, or it has dislodged in its location and has now placed itself in the esophagus. The supraglottic airway being utilized for assisted ventilations is in the incorrect location, or has got a little deep on it. So we've lost end-tidal CO2 off of this. The patient themselves have went into apnea or quit breathing. Endotracheal tube or the supraglottic are not connected to an oxygen supply, or they're not connected to the capnography detector. Low levels really rapidly could mean total obstruction from a mucus plug or mucus plugging that would be partial. If you started to see it stair-step down, which we'll talk about here in a little while, over time, they may have a partial mucus plugging that you can actually see the sampling. Capnography malfunction. Now, if there's vomit that entered into the side sampling or entered into the area, and all of a sudden the machine cannot see the gas sample. So a lot of things can cause this. We should start going through an immediate checklist whenever this occurs or we have a loss of CO2. It could be something as simple as a patient has pulled out their nasal cannula. They could have become apneic. Our ET tube could have been dislodged, but a problem-solving point of view is the way to go with this. Sustained low end-tidal CO2 without an alveolar plateau. Now, this can also be seen in bronchospasm, asthmatics, or COPD exacerbation, and this also would be an incomplete obstruction or mucus plugging. Elevated end-tidal CO2 with good alveolar plateau. Hypoventilation, the patient isn't being ventilated enough due to their illness, injury, or their ventilations. Hyperthermia, pain, shivering, and an increase in metabolism could also do this. More cellular tailpipes producing CO2. Exponential decrease in end-tidal CO2. This could be that the patient is going into cardiac arrest. They have dislodged and have placed in their pulmonary trunk a pulmonary embolism. Sudden hypotension from massive blood loss, like say a AAA goes ahead and balloons out and ruptures. And then if the patient has been placed on cardiopulmonary bypass, we would also see lower and lower amount of end-tidal CO2, and that's because the machine is now functioning as it's a heart-lung machine, so to speak. Spontaneous breathing occurring during mechanical ventilation. This looks like little giblets in between the two capnographic waveforms. So we have waveforms here, and then all of a sudden we will have little spontaneous breaths in between. They can become more prominent. Decision needs to be made. If we want the patient to come out and breathe on their own, that is fine. Be sure that the patient is getting good ventilations. If they are erratic, then very simply provide more knockdown drug. An example of this at IMSA, we would provide some more Versed at that point, or consider calling in a consult for an altering dose of whatever that you might have on the truck. Alternate bronchospasm, and this is the one we mostly see, which is a shark fin presentation. This is from the alveolar not being recruited enough and trapping of air. This is what we might see in a cardiac arrest with a return of spontaneous circulation. All of a sudden we had low end-tidal CO2 levels, and then bam, we're off the chart. So in our next 2-minute cycle, there's a good chance that this person would have a pulse. This is apnea. Where did the wave go? This would be hypoventilation, which would be a steady climb and increase in capnography levels. Hypoventilation would be the number one cause of this. So, in summary, the end-tidal CO2 can give us instantaneous minute-to-minute, second-to-second diagnostic monitoring, and it's dynamic monitoring. It is minute-to-minute, second-to-second. It gives us advanced warning of ventilatory status compromise, and it gives us objective confirmation of clinical assessment. So I think this person may be in respiratory acidosis. Their end-tidal CO2 is very, very high. The machine agrees with me. So please utilize all your tools. References for this slide set was taken from multiple locations. If you have any questions concerning this topic, feel free to contact me. My name is Roy Smith, Smith Arts Samaritan, EMSOK.com, or 405-492-8243. Thank you.